Good evening. Tonight, we're going to be discussing trunk movement assessment. The trunk portion of the body presents unique challenges in the development of functional progressive programs. The trunk cannot be viewed in isolation because it serves as the stable and dynamic base for upper and lower extremity functional progressive programs. An important aspect of developing the functional progressive programs is to understand the biomechanical and weaknesses of the lumbopelvic region. The trunk stability push-up test has the participant in the pictured position and perform 1 to 2 push-ups. The scoring assesses the quality of the push-ups to determine if the body is raised as a unit with no sagging or curvature. Score between 0 and 3. 0 is failed to complete with pain. 1 is failed to complete with no pain. 2 is completely successful from the chin from the men or the clavicles from the women. And a rating of 3 is completely successful from the top of the head for men or the chin for women. Next is the supine trunk curl or curl up as viewed here. The starting position, start in the supine position with your hips and knees flexed. The exercise action is lift your head, neck, and thoracic cage from the floor so that the thoracic cage moves toward the pelvis. The primary muscle groups are the abdominal muscles, in particular, the rectus abdominis. My apologies. Indications: the initial training of the abdominal mechanism. Contradictions is discogenetic pain, radicular pain, compression, injuries of the lumbar vertebral body. Pearls of performance: monitor of the motion of the thoracic cage as it moves towards the pelvis to ensure contradiction of the rectus abdominis muscles. Next is the overhead medicine ball toss. As you can see pictured is the starting position, along with the standing with the weight overhead. So the starting position is a squat with a medicine ball between your legs. Exercise action is to push through the heels and accelerate toward a standing position, simultaneously bringing the weight upward as if to toss it overhead and behind. The primary muscle groups are the spinal extensors, the shoulder flexors, the scapula upward rotators, hip and knee extensors, abdominal muscles to control the rotary motion of the lumbar spine. Indications: the strengths, the spine, and the lower extremity extensors improves in coordination between trunk and the lower extremity extensors. Contradictions: the lumbar extension quadrant testing pain, degenerative changes of the hip joint. And pearls of performance: monitor the patient for correct form. There should be a coordinated, smooth motion between the shoulder gird, the trunk, and the lower extremities. Fatigue or weakness in any one area potentially overloads adjacent areas, making those areas susceptible to injury. Thank you for your time this evening. Have a good night. Good evening. Tonight, going to be discussing lower extremity functional movement assessment. We're going to begin with the forward lunge, the starting position, standing with the feet shoulder width apart and hands on the hips. The exercise action is a step forward with the involved leg until the knee bends to 90 degrees. Return to the starting position. The primary muscle groups, the lower extremity muscular indications, strengthening and stabilization of the lower extremity. Contradictions include limited knee range of motion and parallel femur pain, patellar femur pain. And the pearls of performance ensure the patient maintains the body in an upright position as a step is taken forward. Do not bend the involved extremity to more than 90 degrees when performing the exercise, or steps so far forward that it is necessary to lean backwards to return to the starting position. Next, we'll discuss calf raises. The starting position, stand with feet shoulder width apart and weight evenly distributed. The exercise action, rise up on toes as far as tolerated. Slowly lower and repeat. Primary muscle groups are the gastrocnemius and the soleus. Indications, strengthens gastrocnemius and soleus. Contradictions, there are none. And the pearls of performance, limiting upper extremity support will increase the proprioceptive training. To advance the exercise, have the patient gradually increase weight onto involved foot until single leg calf raise is tolerated. And here we have the single calf raise and double leg calf raise shown. Thank you for your time this evening. Good night. Good evening. This is the upper extremity movement assessment. The assessment of muscular strength in the upper extremity is indicated to determine the presence of muscular strength deficiencies, as well as monitor progress during exercise progression. Use of a handheld dynamometer or isokinetic dynamometer is recommended to provide the highest degree of accuracy and represent muscular strength relationships. The push-up test. Unlike the lower extremity functional testing, the upper extremity has very few functional screening tests, and the push-up test is one of the gold standards in physical education for gross assessment of upper extremity strength. However, the test is considered inappropriate for use in patient populations with shoulder dysfunction. Modification of the push-up has been reported and used clinically as an acceptable alternative for assessing closed chain function in upper extremities. Closed kinetic chain, CKC. Here's a demonstration in a diagram. The closed chain kinetic chain, CKC, upper extremity stability test is a measurement to more accurately assess the functional ability of the upper extremity. The test is initiated in the starting position of a standard push-up for males and modified off the knees push-up for females. 2 strips of tape are placed parallel to each other, 3 feet apart on the floor. The subject then moves both hands back and forth, touching each line, alternating as many times as possible in 15 seconds. Each touch of the line is counted and tallied to generate the CKC upper extremity stability test score. Data has been established with men averaging 18.5 touches in 15 seconds and females averaging 20.5. The windshield wiper plyometric rotator cuff progression. Here's a diagram below. Shows you in the starting position, and you dribble a 2 to 4 pound medicine ball in an arc motion. So the starting position, stand facing a wall about 1 foot away. Raise the shoulders to 90 degrees and bend the elbow to 90 degrees. Place a small medicine ball, 2 to 4 pounds, in your hand. The exercise starts in 90 degrees of external rotation, the forearm vertical position. The exercise action, throw the ball against the wall forcefully, as in the initial rotation drill just described. However, in this exercise, progress the drill along an arc from approximately 2 to 3 o'clock position to the 10 to 12 o'clock position. The ball and hand move back and forth like a windshield wiper on a car for multiple sets. The primary muscle groups are the subscapularis, the pectoris major, the latissimus dorsi, and the trace major. Indications: it improves strength of the muscle that internally rotate and horizontally abduct the shoulder. Also provides a training stimulus for the wrist flexors. Contradictions: shoulder pain, difficulty in overhead positions. This exercise includes overhead reach while performing the dribbling. And the pearls of performance. In addition to performing the exercise with the elbow flexed at 90 degrees, the patient can perform this exercise with an extended elbow. The lawnmower scapular stabilization progression. So you can see the starting position is more down by the foot, and you pull up as if you are starting a lawnmower. So our starting position, standing with your left foot approximately 12 to 8 inches in front of your right. Place a piece of elastic tube or band under the left foot and grasp the other end of the tube or the band with your right hand, level near the outside of the left knee. The trunk is bent at 45 to 60 degrees at a slight left rotation. The exercise action. Extend and rotate the trunk towards the upward position while rocking back onto the right foot. As this whole body motion occurs, bring the right hand toward the base of the right side of the rib cage as you move the shoulder blade into retraction and depression. Emphasize again on squeezing the shoulder blades together as this exercise motion occurs. Return to the starting position and repeat. The primary muscle groups are the scapular stabilizers, the back extenders, and the core. Indications: the scapular stabilization and core stability. Contradictions: the shoulder pain, a history of low back, and scapular dysfunction. Pearls of performance. This open kinetic chain exercise has a primary emphasis on scapular stabilization, but offers a training stimulus for the core as well. Ensure that the patient does not drive the elbow further back than the side of the body or abduct the shoulder away from the side of the body. These compensations decrease the scapular stabilization emphasis during the exercise. Thank you very much. Have a great evening.